Hello everyone. I am DocTutorials faculty. I'm Dr. Murali, vascular surgeon, and we are here to discuss about the NEET recall session for the 2025 questions. And as usual, like every year, we have had like good number of questions from vascular surgery, and I believe most of you have got it right. This is to understand where the question has been taken from, and for the new aspirants who are going to take up the exams fresh in the coming years, they will benefit from the high yield topics and they can concentrate more on this. Let's start with the initial question. So one of the first question is a patient on AZ inhibitor develops a renal artery peak systolic velocity of 250 centimeter per second with a status parvus waveform, hypertension and oliguria. What is the next step? So some of the options given are angioplasty with stenting, switch to other antihypertensives, catheterization with MR angiography. The important things to understand is this patient is having a AC inhibitor, patient on AC inhibitor, having a renal peak systolic velocity. Patient is already on antihypertensive. Patient is having a PSV which is very high. That is like normally, if the PSV is around 2 times higher, we say around 50% of stenosis. But there is a tardive parvus waveform. The tardive parvus waveform says that there is a significant stenosis at the proximal end of the artery, and patient is having hypertension and oliguria, kidney is going for dysfunction. So all this says that patient needs treatment. They cannot switch to other antihypertensive. We need procedure, and the best treatment in this case is angioplasty and without stenting. I maybe some of you may have some questions, but I'll just come in the discussion part. So these are the slides which have been taken up from our classes. These are the classes which are there in the DocTutorials online platform and RRM Next. There is a renal duplex diagnostic criteria. You see that if it is less than 60% of stenosis, it is the PSV is around 180. If it is more than 60% stenosis, the PSV is more than 180. And if there is occlusion, there will be no signal. And moving on, this is the criteria which we use. If it is a less than 50% stenosis, PSV is elevated, but less than the double of the normal adjacent aorta. If it is more than 2%, that is 50 to 74% stenosis. If it is a 4 times stenosis, then it is 70% stenosis. You should plan, and this is to plan the intervention. Duplex is used to plan intervention and part of regular surveillance. The main indications for renal revascularization is this. So it is to improve the BP control and to prevent the end organ damage. This patient is already having end organ damage. We need to preserve the whatever the kidney function which is left, and we need to control the BP. Both the things are achieved by the treatment, so we need treatment. And you see that there is a 70%, more than 70% reduction in stenosis, fibromuscular dysplasia lesion, pressure gradient more than 20%. That is what the catheterization option is for. And affected renal kidney renin ratio is greater than 1.5. So if there is a bilateral renal artery stenosis or a unilateral renal artery stenosis, to understand if the patient is going to benefit from the renal revascularization, we need do the functional assessment like DTPA, renal vein renin assay, and renal systemic renal renin ratio. So these are all useful in case of patient with autologous renal artery stenosis. If it is in case of transplant renal artery stenosis, only if the patient is having any kidney damage, we need to do it. So refractory or progressive hypertension associated with flash pulmonary edema, progressive deterioration renal function, intolerance to antihypertensive medication, CRI, and dialysis dependent. All these are conditions which are require the renal revascularization. So what are the surgical options which are available? We can do an aortorenal bypass, either take the inflow from supraceliac aorta or infrarenal aorta. Hepatorenal shunt, if it is in the right kidney, we can do a bypass between the common hepatic artery to the right renal artery. For the left side, we can even transect the splenic artery and revascularize the renal artery. We can do a bypass from iliac artery to renal artery. We can, for children, you do what is called as a auto transplantation, and if it is a focal lesion, the origin alone, we do an endarterectomy. So final thoughts. So if the patient has been question has been given as transplant renal artery stenosis, the best treatment of choice is renal artery and stenting. But if it is a idiopathic renal artery stenosis in native kidney, open bypass in a fit individual and angioplasty with stenting in a high risk individual is a treatment of choice. If there is a picture like fibromuscular dysplasia saying that the patient is an young female, string of bead appearance, patient is having a narrowing, and there is also involvement of iliac arteries and cerebral vessels, then you should think of fibromuscular dysplasia. Then you don't go for stenting, only for balloon angioplasty alone. Next question. The question is about type B aortic dissection with oliguria and hypotension, most appropriate management. So the options, something which are given were medical management, resection in TIVA and TIVA. So for type B aortic dissection, usually the treatment is medical management. But if there is a complication, if it is complicated, then we need to intervene. So the options of oliguria and hypotension are something which we need to do the procedure. Or for all type B aortic dissection, the treatment of choice is TVAR unless contraindicated otherwise. So the option should be, answer should be TVAR. So this is the same slide which has been there in our classes. So medical management of type B aortic dissection unless there is evidence of rupture or malperfusion. For in this case, we had malperfusion. That is why we are going to intervene. That is why the patient is having oliguria. Patient is having hypotension. It could be even rupture. So usually, if the patient does not have a complication like uncomplicated type B aortic dissection, selective beta blockade to lower the blood pressure, decrease aortic tension, the pulse pressure, anti-impulse therapy is the important treatment of choice. The goal is to reduce the pulse pressure and maintaining end organ perfusion. But TVAR is treatment of choice for complicated dissection with rupture or malperfusion, and as an option for non-complicated patient who is having suspected to have like recurrent dissection, or like patient who needs like they cannot be on they have to be on long term follow-up, they are willing for treatment, we can also do for non-complicated dissection. TVAR is a treatment of choice. So this is something which is included in the new substance, which is an old updated from the Schwartz. So something which you should consider reading more. So another question is about the child with coarctation of aorta was planned for surgery, and during surgery, before clamping distal to the origin of subclavian, the anesthesiologist raises the blood pressure. Reason behind it. There has been some doubts regarding the options which were given. Okay, so we are not the persons who don't have exact questions, or we don't have exact choices which are given. But considering all the inputs which we had from the students, if the question was related to anesthesiologist raising the blood pressure, the answer is to maintain the spinal cord perfusion. If there is a inclusion of intercostal arteries inside the technique infusion inclusion technique, something was given there, then that's also a right answer. But we can understand the principles behind asking the questions. The same thing, the question for this is the top slide which has been taken from our aortic classes. In our discussion, you can go back and read the same slides are there. To avoid the spinal cord injury, secondary to ischemia is very, very important, especially in the thoracic aortic surgeries, thoracic aortic aneurysm, aortic dissection, coarctation of aorta. So, what options to prevent are, you can do either a CSF drainage, we can improve the perfusion, or give hypothermia and pharmacotherapeutics. So, the spinal cord perfusion is determined by the formula mean distal aortic pressure minus the combination of CSF pressure and central venous pressure. If you decrease the CSF pressure or decrease the central venous pressure, the spinal cord perfusion pressure increases. Same way, if you increase the mean distal aortic pressure, then also the spinal cord perfusion pressure increases. That is the reason why the anesthesiologist asked to raise the blood pressure. We'll see the options, we'll discuss them. So to limit the CSF pressure, normally the CSF pressure is around 10 to 15. By putting a CSF drain prior to the procedure and draining a constant 10 to 20 cc rate of CSF, allows the CSF pressure to be slowly falling down. So because there is a spinal cord is enclosed inside the spinal vertebral column, it is a closed space. If the CSF is decreased, there will be no compartment syndrome like picture. So that is the reason why CSF pressure is higher. And the same way, there is two other variables which are related to the mean aortic pressure and central venous pressure. And based on by increasing the mean aortic pressure and also by decreasing central venous pressure, we can also increase the spinal cord perfusion. But CSF drainage is associated with the important risk of postdural puncture headache, and intracerebral, intracranial, subdural hematoma is the most common, along with other conditions like intraventricular, intracerebral, intracranial hemorrhage. EDs can also be seen in case of cases with CSF drain. So the other condition as we saw was increasing the spinal cord perfusion pressure. To increase the spinal cord perfusion pressure, one of the most important thing is intercostal artery reimplantation. The major artery supply of the spinal cord comes from the thoracic aorta. The major artery is called as arteria radicularis magna, which goes by the name artery of Adam Queek's heart. And to reimplant it in case of thoracic aortic surgery is very important. And these arteries are very friable. You cannot dissect it and then include it. So what we do is we include them by a technique called as Crawford inclusion technique. I have a picture for you to show. So that is why the reason of including the aorta, including the intercostal arteries in perfusion has been mentioned. And maintaining the central perfusion is also very important. And to decrease the metabolic rate, we can use preoperative steroids, naloxone drip, and hypothermia and propofol, which are all used to decrease the metabolic rate of the spinal cord. So this is there are two questions regarding this. This is the intercostal artery. This is a picture of patient who is having a aortic dissection open surgery. You can see that we are not taking this out. The arteries which are there in the thoracic segment of spinal cord are all included as a patch. This is called as a Crawford inclusion technique. This artery of Adam Queeks has been a favorite area for examiners to ask questions. And this is the second or third time this question has come. Please note that this is one of the high yield topics. And this is how it ends up. And this is called as a Carroll's patch. The Carroll's patch technique has come in one of the other questions like peripheral vascular revascularization. So this is called as Carroll's patch. We use a Carroll's patch in case of aorta and thoracoabdominal revascularization, visceral revascularization. This is the end point of it, wherein you take the patch of aorta, cut it out, and then implant it into the graft. So this is called as Carroll's patch revascularization technique. So I believe you got the sense of why they have asked the questions and what is the importance of like understanding this. Moving on, this is one of the very, very straightforward questions. I believe they have given you 4 or 5 pictures and they've asked you to click on the choice, which is the type 2 the Crawford thoracic abdominal aortic aneurysm. And this is the straightforward question, I believe. The reason being, this has been there in the Schwarz before, and this has come to light in the new edition of Subiston as well. And so if the aneurysm is extending all the way from the distal thoracic aorta just to the renal artery, it is called as type 1. If it is extending to the bifurcation, it is type 2. And if it starts from the 6th or 7th rib, then it is type 3. And if it is totally intra-abdominal, it is type 4. And type 5 is where it is starting from the 7th rib and stopping short of the renal arteries. So the question is still the bifurcation, it is type 2 TAAA, the second choice in the picture. I hope many of you got it right. And I believe it is because we have already insisted that this area is a high yield topic. Straightforward, simple question, no brain question. And this is another area where they've asked questions. The arterial thoracic outlet syndrome, venous thoracic outlet syndrome has been one of the favorite topics for the examiners. The brachial plexus and subclavian artery are compressed in which are the following spaces. We have 3 spaces: scalene triangle, costoclavicular space, and the quadrangular space, subcoracoid space. So the brachial plexus and subclavian artery are compressed only in cases of scalene triangle or intrascalene triangle. So in case of costoclavicular space, this is the scalene triangle. This is scalenus anterior. You will have scalenus medius posteriorly. So the brachial plexus and the subclavian artery are included in the scalene triangle. This is the costoclavicular space. And you can see that in the costoclavicular space, you can have the subclavian vein, which is coming. It's the only thing which is present there. In case of a quadrangle, in case of a muscular triangle, there are quadrangular space, subcoracoid space. You have nerve, artery, and vein. All are getting involved. But the commonest thing to get compressed is the nerve. And it is not the subclavian artery. There it becomes the axillary artery. It is not the subclavian artery. You need to keep that in mind. So this is the third time the question has been asked. So that is why the two slides. So we have once they've asked you regarding the first rib impressions on the superior surface, and see there is in the medial most will be the subclavius muscle. Then you will have the vein from the anterior to posterior. Then you have scalenus anterior impression. Then you have artery. Then you have the nerve, scalenus medius, and then you can. This is how the order of the orientation in the scalene triangle and the neck is. So the other question was regarding toe brachial index. Some of you said it is TCPO2. Some of you said it is toe brachial index. So most like, I mean, it looked like toe brachial index, not sure. But anyways, we just discussed it so for us to understand. Toe brachial index Less than 0.6 indicates significant arterial insufficiency, not reliable in diabetic patient. Co-arteries undergo sclerosis, hence not useful. Less than 70 millimeter is significant. They have asked you regarding the true statements. It is one of the straightforward questions, I believe, because it is the answer is that there is no dubious things. Toe brachial index less than 0.6 suggestive arterial insufficiency. So toe brachial index TBI is the use of photoplethysmography probe, which is there tied to the great toe, and we measure the brachial artery as the denominator. Normal toe pressure is 30 millimeter less than the ankle pressure. So if the patient is going to an upper limb pressure of 120, the ankle pressure is going to be around 100 or 110 minimum, that is 0.9 ABA or 120. So 30 to 40 millimeters less is around 70. So somewhere between 70 to 80 will be the normal toe pressure, and TBA less than 0.7 suggests a PAOD. And usually pedal vessels are spared of atherosclerosis. That is why we use it. They are spared of calcification. But the problem being, if the patient is having an amputation or ulcer, it is not able to use it. And since there is a confusion regarding TCPO2, and TCPO2 is something which has been recently added in the substance as well, I thought I'll make a mention of it. TCPO2 is a metabolic assessment. Metabolic assessment. It assesses the local tissue perfusion in the and assesses the potential to for the healing of the wound. So if the TCPO2 is less than 60, that is also suggestive of patient is having a good vascularity. If the TCPO2 is less than 30, that means the patient is going to have a failure of healing. So anything which is more than 60 is very good. But if the patient, there is also affected by local condition like warm, local surrounding temperature, patient is having status, what is his blood pressure like, what is the drugs which is on any vasoconstrictors or anything. So these are all going to affect the TCPO2. So, but you should keep in mind, since they have asked TBI, ABI, TCPO2 has been a constant question topic, I believe we should be able to crack it. And toe brachial index, toe pressure, as we said before, less than 0.75 is abnormal. Toe pressure less than 30 millimeters suggests of critical limb ischemia, and toe pressure less than 60 is associated with significant likelihood of healing, non-healing. So that was another question regarding a picture. It's an image-based question, and they have asked you regarding whether it is C4A, B, or C4C, C classification based on varicose vein. I believe this is the picture which was given to you. And the question is another very, very straightforward question. There was no dubiosity, I believe, because if the question is picture is good, the answer should be straightforward. So if the patient is going to have only pigmentation, no edema, if the patient is going to have only pigmentation or eczema, then there is going to be C4A. If the patient is going to have a swollen leg and it is narrowed down bottom, that is the patient is having atrophy blanchia or lipodermatosclerosis, then it is C4B. C4C is ankle. So if you have a lot of varicosities along the telangiectasias around the ankle, it is called as C4C. There is no C4D. It is only a googly which was given there. So there is nothing much. It is only the CEAP classification which was asked. This is also one of the repeated areas where they have asked questions. And this question we have also framed a couple of questions for you to assess the CEAP classification in our classes, both online and offline, so that we have insisted that this is one of the high yield topics, both in our regular classes and revision classes. And other question was around superficial crural veins, the venous flow retrograde measurement, the reflex flow in physiological duration. So the options was 0.5, 0.12. So they've asked you what is the answer. So anything, the question is not very very honest, very straightforward, I will say. If they have asked you for a physiological assessment, anything less than 0.5 is physiological. So 0.25 should also be an answer. But I'm not sure what they have asked you. But if it is less than, if they've asked you less than which level is significant, then 0.5 is an answer. If they've asked you which are all physiological, both 0.25 and 0.5 are answer. Which are all pathological, both 1 and 2 are answer. So this is a picture which was taken from, this is a slide from our class presentation in varicose veins, chronic venous disease topic. So whenever we look for duplex, we look for a presence of obstruction, old history of DVT, presence of reflux in the deep veins and superficial veins. If the reflux in the deep veins is more than 1 second, then it is a significant. If the reflux is more than 0.5 seconds in superficial veins, crural veins, then it is significant. So if it is less than 0.5, then it is physiological. So in that case, both 0.5 and 0.25 are answered. If they ask for a level below which it is a cutoff, then 0.5 should be the answer. That's why I chose 0.5, because I'm not able to extract the exact wordings which are asked in the question. And going on, the other things which we should know in varicose veins are, you should also know about exact distribution and reflex in the superficial venous system, and suitability for treatments and presence of thrombus, superficial venous thrombus, which is present or not. And also you should look for pelvic venous insufficiency. That is also very important. Whenever you assess a case of varicose veins, you should not only assess deep vein pathology, deep vein reflex, superficial vein reflex, you also assess a pelvic source of venous reflex or obstruction. So, couple of last few questions. So, the correct sequence of pathogenesis in diabetic foot. So, this we have discussed, but we have not discussed in the exact format. So, the answer should be the neuropathy, ischemia, ulceration, infection, and amputation. So the reason why we have taken up, I have shared the sources. So ischemia, this is the left one. A picture on the left is a picture from the Bailey and Love 28th edition. The picture on the right is the Subsistent New edition. These are the pages has been given. So usually the most peripheral sensory neuropathy is the most common, and ischemia is the second most common etiology for diabetic foot wound. And they causes ulceration, and the ulceration causes infection to enter the body, and which can lead to gangrene or amputation. So this is the sequence which is usually there. There is a neuropathy, there is an ischemia, or sometimes it is both together, which leads to a wound and which causes infection, and then it progresses on to gangrene or amputation. So ischemia can either be this is a slide which was there in our book, where in our classes. Ischemia is a macrovascular disease, which is atherosclerotic, and there will be sparing of pedal vessels. This is asked in the TBA question, the toe brachial index question, and increased microcirculatory shunting and dysfunction, microvascular dysfunction will be there. This is the reason why they develop neuropathy also. The microvascular dysfunction, the neuropathy will be there, autonomic neuropathy will be there, and early microvascular shunting will be there. Because of the vascular dysfunction and the neuropathy, they develop Charcot's foot, which causes the potential for ulceration. And neuropathy worsens it because they don't see the wound early, and superadded infection leads due to poor wound care, leads to rapid progression of the wound and amputation. So one other question was how PTFE graft is anastomosis artery with a small collar of vein is called as. So the Carroll's patch option, which we saw before, which is used in cases of arterial buttoning in case of TAAA repair. There is Schnellenberg anastomosis, I believe, is a blooper. It is just asked for the sake of it. And we have discussed this. So this is the reference where they have taken the question from. These are all like not very commonly asked area, but they used to ask techniques. They have asked about iontobifemoral, they have asked about lower limb bypass technique, but this time they asked about prosthetic graft and how it is used in the distal area. So these are the topics which these are the options which are given. This is from the Subsistent and the Bailey, and they use vein patch, cuff, and distal AV fistula. I shared some of the picture. This is the picture which is there in the Bailey, where it shows that, and this is the Bailey picture, and previous one is a Subsistent picture. And this is what we should know. If we use a vein cuff, it is called as a Miller's cuff. If it is a vein which has been rotated and sutured, it is called as a St. Mary's boot. And if it is a dorsal patch, it is called as a Taylor's patch. The picture on the right extreme is a Linton's patch, which is there, which we have discussed in our class. This picture on the right is there in our classes and in our discussion and our notes, but we have not discussed the name of it because we thought they may not ask you the question. But as we believe, they can ask you anything. They can because these are all something which we prefer to ask in our vascular surgery postgraduates. But because they have given you a lot of easy questions in vascular, they had to ask you one difficult question. So I believe this is one of the difficult questions which they have asked. So this is the Linton's patch after endarterectomy. And this is the AV fistula which we create to improve the. See, this is a proximal artery, this is a distal artery. We anastomose the nearby vein along with the graft. So we create a AV fistula, and the graft is landed on the AV fistula. So this ensures that the graft flows through distal artery and along the vein. So this helps in improving the patency of the graft. So these are the techniques which are used to improve the patency in cases of AV prosthetic graft revascularization. So this brings us to the end of discussion of questions regarding vascular surgery. I believe we have discussed almost all the topics. I believe you have a lot of questions. Um, I may be there is a room for error which is there in this presentation, in the sense like we have not said that exact questions. We do not know the exact wordings, but we know the exact questions area based on the recalls. And I believe most of you should clear the exam. Whoever have given the exams should clear the exams. And I hope you have got all the vascular questions right. And I am whoever have cracked the exam and have benefited from all the materials which we have provided you. I'm very thankful to you for studying them through. And I am very proud to say, I'm very happy to say that around 90 to 95 percentage of questions have been taken from the materials in the vascular surgery. So just by reading the vascular surgery notes is more than sufficient. Just by reading the presentations is more than sufficient to crack 90 percentage to 93 percentage of the topics. So that is quite high. And I think like we should concentrate more on the questions which have been discussed, topics which have been told to be high yield, so that we can crack the exams better. So whoever are preparing for the exams in future, please do concentrate on the high yield topics. Please do concentrate on this area where the questions have been asked prior, and this will help in when making sure that we have we are addressing the 90 to 95 percentage part. The rest 10 percentage is where by reading lot of repeated reading of textbook, repeated reading of extra materials helps us. So from the vascular perspective, they've asked you regarding from the questions have been from Bailey, questions have been from Subiston, and they've also asked questions from the newer edition of Subiston or like the Schwartz, which is quite straightforward, I believe. And the one thing which I request all of you to do is, from the vascular surgery perspective, is to concentrate on the notes. And if you have any doubts regarding our notes or like any doubts regarding the recall which has been there, I'm very happy to discuss it through our vascular group in our WhatsApp group. And thank you for listening to the stream. This brings us to the end of vascular questions. There are a couple of lymphatics questions. There are at least 2 to 3 lymphatics questions. Professor Dr. Vijay sir is taking the lymphatics. Our plastic surgery faculty is happy to take the lymphatics question. So he will be discussing the lymphatics question in this session. Thank you.